Very good evening to one and all of you for this very wonderful webinar. And I'm truly on behalf of the Eye Foundation group of doctors indebted to you all for creating time to be with us. And I'm sure the learning process which is going to accrue in the next 3 hours is going to be just amazing. And these are very niche topics, and I'm sure it's going to be of great value addition to one and all of us. We are truly proud to have an absolute galaxy on the expert panel. We have with us Dr. Hemant Murthy, our very own dear Dr. Hemant Murthy, who is a senior Vitreous retina consultant, medical director of the Retina Institute of Karnataka, is an ace surgeon and a winner of the Reed Buckler's Award of multiple times. And we are proud to say that he's been an amazing president of the Karnataka State Ophthalmic Society. We have with us joining soon Dr. Jatinder Singh, who's a senior Vitreous retina consultant, another very amazing skilled surgeon from our Eye Foundation group of hospitals. We have joining us soon Dr. N.S. Muralidhar, who's first and foremost our very honorable president of the Vitreous Retina Society of India, and also the president of the Retina Institute of Karnataka, and is one of the senior most retina surgeons in Karnataka. We have with us Dr. Ramandeep Singh, who's a senior professor of retina and uvea from PGI Chandigarh. Thank you so much for giving us this time to be with us, Doctor. It's with great pride I would like to mention names of our international faculty who are on the expert panel. One is Dr. Professor Riaz, who is again a very renowned ophthalmologist and professor with over 25 years of experience, is the chairman of the Department of Ophthalmology at the Institute of Ophthalmology at Cairo. We have with us Dr. Mahmood Leela, who's a senior Vitreous retina consultant from the Retina Department, the Research Institute of Ophthalmology from Giza, Egypt. We have joining us soon Dr. Barbara Parolini, and again we are truly enlightened to have all the staff faculty with us, a senior Vitreous retina consultant, and there's a director of Vitreous retina services from the Institute of Brescia, Italy. And it's my pride to have Dr. Ashray as my co-moderator, or rather the lead moderator. And he's again a young Vitreous retina consultant with so much energy and vitality. And he only cheer-picked every single speaker and expert panel, and I owe the whole meeting and its credit to him. Our first speaker is going to be Mrs. Dr. Riddhima Deshpande, who's a Vitreous retina consultant from Evista Eye Hospital, Nagpur, and she's going to set the ball rolling with the topic, role of fundus imaging and clinical examination in pseudo-hole, lamellar hole, and macular hole. On to you, Dr. Riddhima.
Thank you so much, Dr. Chitra, for the kind words. I'd like to thank Dr. Chitra for this wonderful opportunity, and I'd like to wish everybody a very happy Pateti. I'll share my screen now. I'm going to talk about the role of fundus imaging and clinical examination in pseudo-hole, lamellar hole, and macular hole. So this is the agenda of this presentation. We all know that macular hole is a full thickness defect at the fovea from the ileum to the RP. It was first reported by Knapp, and this term was coined by Ogilvy in the year 1900. Prevalence is 3.3 per 1,000 population. It's usually unilateral, and women are 3 times more likely to develop a macular hole as compared to men. Of all the hypotheses concerned regarding the pathogenesis of macular hole, the theory of anteroposterior traction is the most widely accepted one. So in eyes who are predisposed to forming a macular hole have an abnormal vitromacular adhesion, which exerts dynamic traction at the fovea. Along with this, there is contraction of the collagen and avulsion of the Mueller cell cap. Now, this avulsion of the Mueller cell cap predisposes to formation of primary full-thickness macular holes. Tangential traction, which is exerted by the residual vitreous cortex at the macula after separation of the vitreous, and the constriction or the contraction of the proliferating glial cells are responsible for the tangential traction, and they have a role in enlargement of the full-thickness macular hole. Secondary full-thickness macular holes are due to other causes, and they are not associated with concomitant VMT. Now, the first biomacroscopic classification was proposed by Donald Gass in the year 1988. Now, it has 4 stages. Stage 1A appears as a central yellow spot. 1B is an occult hole with a yellow ring. Stage 2 appears as an eccentric oval around defect less than 400 microns, which is present well within the edge of the yellow ring. Stage 3 are defects more than 400 microns. They're not associated with PVD and may show pseudo-operculum. And stage 4 are full thickness defects more than 400 microns and are associated with complete posterior vitreous detachment, which appears as a Weiss ring on biomicroscopic classification. The newer classification systems are OCT based. Now, this IVTS classification was proposed in the year 2013. It has classified macular holes depending on the size, that is the minimum linear diameter, depending on the presence or absence of VMT, and depending on the cause into primary or secondary macular holes. Now here they've introduced a new stage, that is stage 0, which is vitromacular adhesion, where there is no change in foveal architecture. Stage 1 is VMT without a macular hole. Stage 2 are small or medium-sized macular holes with VMT. Stage 3 correspond to large macular holes without a VMT, and stage 4 of the gases classification corresponds to small, medium, and large holes with a complete PVD and no VMT. Now, the E3 consortium has given a OCT classification, which classifies holes into small, medium, and large holes. Small is less than 250, medium is between 250 and 400, and large holes are more than 400 microns in diameter. Looking at the biomicroscopic findings, now, this is the stage 1A hole where you can see a central yellow spot. There is loss of foveal depression, and you can see fine striae on the retina. Stage 1B, where you can see a yellow ring at the center, and there is loss of foveal depression. There is no PVD, and there is a centrifugal displacement of the foveolar retina and the xanthophyll, which gives rise to a yellow ring. And sometimes you can see this bridging contracted perifoveal vitreous, which can be seen on the temporal edge of this yellow ring. Then this is stage 2 hole, which appears as a well-rounded defect, which is present inside this yellow ring. These are stage 3 macular holes, which are defects more than 400 microns, and full thickness macular holes associated, large full thickness holes associated with a complete PVD. Now, these full thickness holes can be associated with an ERM. They can have a cuff of subretinal fluid. They can show these yellow spots at the center of the hole, which is presumed glial proliferation. And sometimes they can show this hypopigmented ring under the area of detachment. Most of the stage 1, stage 2 holes have visual acuities of 20/60 or better, and they're either asymptomatic or present with mild metamorphopsia. 50% of stage 1 holes show spontaneous regression, and 40% continue to enlarge, whereas 50% of stage 2 holes show spontaneous closure, and 75% continue to enlarge. Now, if you look, almost 70% of patients with early macular holes show typical pincushion defects. If you look at the image here, now there is, inward pulling of the facial features towards the point of fixation. Also, the Amsler's grid shows dragging of these lines towards the point of fixation. These are pincushion defects, which are seen in patients with early macular holes. Another clinical test is the Watzke-Allen test on slit lamp, where you project a normal slit beam on the fovea, and patient with a full thickness defect will be able to see a break in this beam of light. Then you have the laser beam aiming test, which appears to be most sensitive for a full thickness macular hole. These are the several imaging modalities for a macular hole. You have structural OCT for evaluating the structural characteristics. We'll also look at the several biomarkers that you can see on OCT: fundus microperimetry, OCT angiography, blue fundus autofluorescence, and adaptive optics. I think I will skip through these slides. Okay, so coming to the IVTS classification, you can see a VMA, that is vitromacular adhesion. So in this OCT image, you can see a broad VMA, which is more than 1500 microns. Then you have a vitromacular traction. Here you can see a focal VMT with inner retinal changes, and small full thickness macular holes, which are less than 250 microns. You can see an associated PVD. A medium full thickness macular hole, which is between 250 to 400 microns. In this image here, you can see a flap which is adherent to the vitreous, and large full thickness macular holes. Here you can see a posterior vitreous detachment with a pseudo-operculum. There are several parameters to assess a macular hole, and they're important, and they have an important prognostic value as far as functional and surgical outcomes are concerned. So the most critical one of these is the minimum linear diameter, because it has been found that smaller the MLD, better is the visual prognosis and surgical outcomes of the patient. The other indices are the hole forming factor, which is a ratio of the right and left arm lengths to the base. It has been found that HFF values of more than 0.9 are associated with better outcomes. The macular hole indices, or MHI, is a ratio of the height to the base of the macular hole. MHI levels of more than 0.5 is associated with better prognosis. DHI is the diameter hole index, which is a ratio of the MLD to the base, and THI is the tractional hole index, which is a ratio of the hole height to the MLD. A higher THI level and a lower DHI level is value is associated with better visual outcomes and surgical outcomes after macular hole surgeries. Coming to other biomarkers, what you can see here is the ELM, that is the external limiting membrane, the ellipsoid zone, and the interdigitation zone defects. Now, A and C are preoperative OCTs of patients, and B and C are postoperative OCTs of patients of macular hole. You can see in the OCT B, there is complete restoration of these 3 bands after a macular hole surgery, whereas in OCT D, there is associated foveal atrophy. So it has been found that restoration of these bands in the postoperative period is associated with good visual and functional outcomes. There is no consensus regarding the role of or the prognostic value of intraretinal cystoid spaces, but one study from LVP Hyderabad by Dr. Jay Chablani has shown that presence of these cystoid spaces may be associated with good visual and functional outcomes, provided a good amount of functional retinal tissue is present at the site of the macular hole. Supra-RPE hyperreflective granular deposits are indicators of photoreceptor damage. So this is associated with poor visual prognosis. Atypical retinal tissue or epiretinal proliferation appears as a medium reflectivity tissue above the ILM. Presence association of FTMH with epiretinal proliferation is associated with worse outcomes. Coming to blue fundus autofluorescence. Now in the this image here, you can see a full thickness macular hole, and corresponding OCT also shows a large full thickness macular hole. If you look at the blue fundus autofluorescence here, you can see a classical pattern where you have a central hyper autofluorescence spot that corresponds to the macular hole. This is surrounded by a hyperreflective hypoautofluorescent ring, and this is surrounded by a zone of relative hypoautofluorescence, where you can see these radiating dark striae. Now, this pattern has been seen in around 70% of patients with full thickness holes. If you look at the corresponding OCTs, now the OCT across the center hyperautofluorescent spot actually corresponds to the full thickness hole. Now, across the hypoautofluorescent ring shows presence of SRF in the OCT. Whereas if you take an OCT across these striae, you can see that these dark striae are actually the cyst walls, and the relative hyperautofluorescent centers are the cyst area. And if you compare this with the fundus microperimetry, you can see absolute scotoma corresponding to the full thickness macular hole. And then there are areas of reduced sensitivity around it, which corresponds to areas of abnormal autofluorescence. Now, OCT angiography and NFAS OCT are another important imaging modalities for pre and post-operative evaluation. Now, in an OCT, the deep capillary plexus and the choriocapillaries have shown flow voids and alterations in the flow. And if you see the corresponding NFAS OCTs, you can see these hyporeflective space which corresponds to the macular hole. You have these rounded spaces, hyporeflective spaces at the level of the inner nuclear layer. And then you have this surrounded by these radial hyporeflective spaces, which giving it a stellate appearance. Now, this pattern is also seen in large full thickness macular holes. In the postoperative period, you can see there is improvement of vascular density in the deep capillary plexus as well as the choriocapillary plexus. So restoration of the flow in these deep capillary plexus and choriocapillaries has been associated with good functional outcomes after a macular hole surgery. Coming to adaptive optics, now this is used to study the cone mosaic as well as the cone density. Now the top image, this is the confocal image which shows multiple hyporeflective areas which appear as dark areas. Now, these hyperreflective areas correspond to zones of IZ disruption, that is interdigitation zone disruption in an OCT. Now, subsequent images are the postoperative images of the patient at several time points, and you can see that slowly, gradually, there's an increase in the improvement of the cone mosaic and improvement in the cone density as well. So again, this is a good prognostic factor. This is important, fellow eyes of a macular hole. Now, 6 types of shallow PVDs have been identified, and it has been found that type 3 and type 5B shallow PVDs are observed in eyes with are observed in fellow eyes of a macular hole and not in normal holes. Type 3 PVD is a shallow PVD with pinpoint foveal vitreous traction, whereas 5B is a shallow PVD with a pseudoperculum. Type 2, which is a shallow posterior vitreous detachment with a smooth perifoveal vitreous attachment. This has been found more commonly in normal eyes. Coming to macular pseudoholes and lamellar holes.
I think you have to conclude your talk.
Okay.
Yeah.
Just I think, okay.
Yeah, complete it. Yeah.
Okay. So macular pseudohole appears as reddish round oval punched out defects 200 to 400 microns in size. They're associated with tortuosity of parafoveal vessels, partly obscured by the semi-transparent membrane. There is no marginal zone of retinal elevation or no discrete yellow spots. The IVTS classification has defined macular pseudoholes as having invaginated or heaped foveal edges, concomitant ERM, which is the most characteristic feature. There's a steep foveal contour, and there is no loss of retinal tissue. Whereas lamellar macular holes are partial thickness foveal defects, which on biomicroscopy appear as reddish lesions, which are well circumscribed. Prevalence is 1 to 3.6%. Again, the IVTS has given the definition for a lamellar hole as having irregular foveal contour, defect in the inner fovea. There is intraretinal split at the in the retina, which has a schisis-like appearance, and maintenance of an intact photoreceptor layer, which is a way of differentiating lamellar holes from full thickness holes. Again, lamellar macular holes can be classified into the tractional or degenerative types. The tractional lamellar hole is associated with the conventional ERM and an intact ellipsoid zone, whereas a degenerative lamellar hole is associated with epiretinal proliferation. There's a disruption of the ellipsoid zone. There's a foveal bump and rounding of the edges of the intraretinal cavities. I'm just going to skip through these slides. So these are basically the 4 developmental pathways. These are several parameters to measure a lamellar hole and pseudohole. So it has an inner diameter, a base diameter, a depth. This is a central foveal thickness, and the white arrows at 750 microns on either side of the center where the foveal thickness is measured. It has been found that lamellar holes have a thinner central foveal thickness. They have a wider base diameter and have deeper defects. Perifoveal thickness is similar in both the conditions. It's been found that increase in the size of lamellar hole is associated with drop in the visual acuity and drop in the central foveal thickness, which means that thicker the central foveal thickness, better is the visual acuity. So pseudoholes might have a slightly better visual acuity as compared to lamellar holes. A wide intraretinal split having a bilobate contour is associated with poor visual prognosis, and epiretinal proliferation also is associated with poor visual prognosis. Fundus autofluorescence has currently challenged the OCT challenge the OCT diagnosis of these conditions. So if you look at the OCT, you will label it as a pseudohole. But if you look at the fundus autofluorescence, you can see a hyperautofluorescent spot, which indicates pigment loss. Therefore, it's an indirect indicator of tissue loss. So the diagnosis changes to a lamellar macular hole. All these are examples of lamellar hole, and all the fundus autofluorescence image here show presence of hyperautofluorescence at the macula, indicating tissue loss. Again, the sensitivity in a microperimeter retinal sensitivities are reduced in the area of abnormal autofluorescence. On an NFAS OCT in a ERM foveus schisis, you can see signs of traction. You can see these dark folds and wrinkling. At the level of the outer nuclear layer, you can see a typical radial spoke wheel pattern, increased hyperautofluorescence at the macula, and on the IR image you can see wrinkling of the inner retina, which is more pronounced on the green reflectance image.
Can we
to Dr. Riddhima, because
Okay.
you're way beyond 8 minutes.
Okay, sorry. So just to summarize, normally in a macular hole diameter, ELM, EZ, and IZ defects, supra-RP granular deposits, bumpy hole borders, epiretinal proliferation, and alterations in the deep capillary plexus are usually associated with bad visual and functional outcomes. And improvement of vascular density in the postoperative period on an OCTA and improvement of foveal cone density on adaptive optics is a measure of photoreceptor integrity and have better visual prognosis. Thank you.
Thank you. Thank you, Riddhima. That was quite exhaustive. Just one question to quickly move on, because Riddhima has covered quite a few things on imaging modalities. I just want to talk what to the Dr. Hemant, Dr. Muralidhar can say. What are your top three macular hole impersonators or
Can you stop
mastigators?
sharing, Dr. Riddhima?
Sorry.
Macular hole impersonators, I would say, is all the pseudo holes or lamellar holes impersonate on a clinical examination, not on OCT. But the other on clinical examination, I would see sometimes even and MACTEL appears like a macular hole on clinical examination. But on OCT, I think you're much more better and you're fairly clear on your diagnosis.
So, Jatinder sir? Jatinder sir? Anything you want to add on?
As Dr. Hemant said, I don't think on OCT there is much confusion on the types of macular hole. Sometimes a so-called pseudo hole on clinical exam can be a lamellar hole on OCT. So clinical and OCT mismatch can be there, but OCT, if we follow the definition and the criteria of diagnosis, I think that settles the diagnosis, and we can, I think, irrespective of whether it is lamellar hole or pseudo hole, the traction and the other features, biomarkers which are mentioned, that would determine the outcome of the surgery, and the indications of the surgery are also settled based on that. So the thickness of the at the fovea, the integrity of the ellipsoid zone, and the interdiscretion band, that is I think the main criteria that we need to look into. I also get an autofluorescence done before any of these surgeries, whether it is macular hole surgery or ERM or pseudo hole with any foveal traction, perifoveal traction. That gives me an idea of how much of like iatrogenic trauma is there, and whether that correlates with the functional outcome post-operative.